Welcome once again to the third and final edition of the ERIN Webinars for this year, organized by EAHAD in coordination with EAHAD and dedicated to bleeding disorder of unknown cause. My name is Stefan Radovanovic. I'm the patient engagement and community lead at EAHAD. And today, with my dear friend Fiona Brennan, the EAHAD's advisor, I will be facilitating the discussion about this widespread disorder and hopefully lifting the veil of the unknown surrounding it. The data show that among individuals with a clinically relevant bleeding tendencies referred to hemostasis experts, more than half, that means more than 50%, and some sources show to even higher number, up to 60%, had no identifiable biological cause and thus were classified as bleeding disorder of unknown cause. The symptoms vary considerably among these patients, even though they often share a similar overall pattern of mild to moderate bleeding tendency. This means that this topic is much more relevant to us and present much more than it might seem to us, and that we must pay much more attention to this disorder and the people affected by it. So finally, I want to mention that today's program is divided in two parts. In the first part, you will be hearing from our speakers, but in the second one, in the Q&A part, we would like to hear from you as well. And that is the reason why the format of the webinar is organized more as a meeting type than a standard webinar format. Because in this format, you will be able to turn on your microphones, and besides your chance to put your questions in the Q&A section, you can also weigh in live and add to the hopefully fruitful discussion by raising your hand. So please feel free to choose your preferred way of communication with us and our dear speakers. And talking about speakers, I will try to keep it short, so I will stop talking now so they will have time to present, to talk about their presentations, and leave it now to Fiona to weigh in and introduce them to you.
Good evening, everybody. Thank you, Stefan. It's absolutely my pleasure to introduce somebody that I've known far too long at this stage. So Mary Flanagan is a patient representative. She is also a fellow Irish woman. She was diagnosed with a bleeding disorder of unknown cause around 2016, and she attends the National Coagulation Centre in Ireland in St. James's Hospital. Coincidentally, or maybe ironically, her husband has severe haemophilia A, so Mary has been involved in the Irish Haemophilia Society, which was the patient organisation in Ireland, since 1996, and became active and a member through her husband originally. Through this, Mary has discovered the ERIN committee and the work of ERIN through EHC. She joined webinars and presentations and ultimately attended her first ERIN summit in Zagreb in 2024. And as she learns more about her own condition and treatment, Mary has become super passionate about advocacy. She hopes that by sharing her experiences, she can help others navigate similar challenges and encourage greater awareness in both clinical practice and care for patients with bleeding disorders, rare bleeding disorders, and their families. So Mary, with pleasure, over to you.
Hi, everybody, and thanks very much, Fiona and Stefan. Again, just to reiterate, my name is Mary Flanagan. I live in Ireland, just Fiona has said. I have a bleeding disorder of unknown cause, diagnosed relatively later in life. In my day-to-day work, I'm an events administrator, and I have been strongly involved, as Fiona said, with the Irish Haemophilia Society since 1996. And that is because my husband, David, has severe haemophilia A, and I suppose I married into it. Yes. So as I suppose I would not have maybe cottoned on to the fact of having a bleeding disorder if it weren't for my involvement with the Irish Haemophilia Society and been around people for that period of time with bleeding disorders. So I suppose if I didn't know, I wouldn't know anything. And that puts you in a dangerous position. So I suppose to give you the background to it, I'd start with my earliest experiences. I suppose I would always have had heavy periods. Then again, the women in my family always did. So that was our normal, if you like. I'd have been slow to heal from cuts and grazes. I'd bruise fairly easily. Nothing dramatic, and certainly nothing out of the ordinary for our family experience. And I suppose that's a line or a thread that I have heard repeated in recent years through my involvement with ERIN. Other people in a similar situation are going, well, didn't really pay much attention to it because that's what it was always like in my family. So I've been fortunate enough in my life never to have really suffered any trauma or required any surgeries that would have impacted me to the point that it would have highlighted anything greater than that which I was already used to. So again, as I say, fairly normal. The only issue that I would notice was, say, in the region of, say, dental, where my gums would bleed, or say when I would have an extraction or any kind of work, it would bleed not overly significantly, but longer than would be expected. So anyway, as time went on, periods seemed to get longer in length and stronger in intensity. And I just thought, that's just my lot. That's just the way it is, you know? So it wasn't until our son was born that these things started to kind of ramp up. I actually suffered a hemorrhage after my son was born in the early 2000s. Now, in the early 2000s, those of you who are familiar with the medical history in Ireland at that time, there were a lot of very tragic circumstances around maternity care with women in Ireland at that time. So it doesn't really come as a major surprise that things were overlooked and that I was in fact never told that I had a hemorrhage. It was some years afterwards that I discovered why it was that I was so desperately ill after the delivery, why I came back wrapped in tinfoil being treated for shock. Now, I wasn't given blood, so we just didn't know. It was a traumatic delivery. And when I went to follow up with my consultant afterwards, the response I got was, and I'm as near to quoting as I can, these things happen, you need to get over it, you have your child, go home and forget about it. So I did. And not long, say, in the time frame after that, we decided we would like to have more children. But the periods and the fertility issues that surrounded it, we thought it was part to do with the bleeding. I had had DNC procedures. Again, I would always come out that never too well because they would have to keep me under for longer because of the fact that there would be more blood in the uterus than they were expecting to find when they got in there. And that would always be what I was told. And again, I wasn't putting this together as a bleeding disorder. So time went on, the bleeding got more pronounced. Items like, or issues like the issues with the DNCs and those procedures, issues like I had 2 miscarriages and they resulted in DNCs as well. And again, the same issue, there was a lot more bleeding in there. Then time went on and the issue came up then about, say, accepting that part of my life was over. And the issue then went on about the periods, and the focus became about how heavy they were getting, how invasive into my life the whole issue around it was, that it would be very large clots. I would have to not leave the house. I would sometimes be out of the house and I would have to get something to cover me to get back to the house, wash my clothes, take another shower, that kind of thing. These things were coming up a lot. So I had been with my gynecologist. He had done a thermal ablation to try and cauterize the inside of the uterus to stem the bleeding. It didn't work. Then I had a coil fitted to stem the bleeding. It didn't work. So they then decided to put me on tranexamic acid or cyclopram. At that point, my GP stepped in and said, because I had had a pulmonary embolism previously, that I couldn't take cyclopram. And he then referred me to the National Coagulation Centre in St. James's Hospital in Dublin. So it was at that time that the issue of a bleeding disorder came up, because the bruises that I was getting as well, they were just coming out of nowhere and they were quite severe. And being married to a haemophiliac, I wasn't rating them because I was going, that's not a bruise. I've seen bruises, those aren't bruises. But they were getting fairly significant. So the NCC ran their blood tests and they came back with this diagnosis of a bleeding disorder of unknown etymology, I think was the original word, and now is unknown cause. So the idea then was that the only solution to this was a hysterectomy. And that was Sophie's choice, if you like. They're telling you you have a bleeding disorder and introducing the concept of a fairly significant surgery. So it's either that or you put up with the bleeding and the inconvenience and the disruption and the embarrassment of it and all of those kind of things. Now, emotionally and psychologically, given the fact that I had suffered miscarriages and had fertility issues and just felt like my body was letting me down over and over again, I did not feel emotionally or physically able to face an hysterectomy. So I decided I'd run out the clock and I would just wait for nature to take its course, which took actually several years. I was very late getting to menopause. The sad thing is that I subsequently found out that I could have and should have been given cyclopram. I'm not here to apportion blame in any way, shape, or form. This is what happened. We learn more. We learn from people's experiences. Hopefully my experiences will feed into learning for other people. But what I endured in the discomfort of it, in the worry and the torment, and what I could equally have had taken the decision of the hysterectomy, but because there wasn't enough known about it, I was left in that position. So I suppose I am in a very fortunate position that I am generally in good health, and apart from bruising or the incidence of, if it's a surgery or a trauma, I don't need treatment. So what I'm looking at is the coming up to the present day and looking at the treatment and the care of people with bleeding disorders of unknown cause and I lengthily, I suppose, gave my background and my lead into it, because not everybody knows immediately that they have it. Not everybody recognizes it immediately. You would think with my experience, I would have spotted it sooner, but I didn't. But my involvement in it, I suppose, into ERIN was through Jim O'Leary of this parish that had introduced me to ERIN and had also introduced speakers into our national member organisation, speaking about very rare bleeding disorders, women's bleeding disorders, and opening up that avenue of discussion. And I went along to those, and I was amazed that this was, that there were so many people who went, oh yeah, that was me, and we had identifiable similarities and all the rest of it. So it came to my mind that the experiences that I had need not be endured by anybody else. And I'm not, I know people have had unbelievable experiences and unbelievable sadness and trauma and endured so much. And I am very acutely aware of that through my husband. But I am reminded, I suppose, in a profound way, and I think back to his childhood, being born, he was a spontaneous hemophiliac occurrence in his family. So little to nothing was known in the country at the time. Treatment was rough, to say the very least of it. So I suppose coming into rare bleeding disorders, so little is known in the broader community, but so much is actually known. There is a lot of information out there. There is a lot of research, diagnostics research, it's all developing. But people out on the grassroots, whatever, aren't aware of it, aren't aware that there are issues, aren't aware that there are options. And I feel that I should actually advocate, and I should come along, and I should speak, and I should put forward these experiences. My most recent experience, I suppose, and this is where I'm kind of coming to for people, and I suppose people will identify this a lot. Here's the crux of the issue, having blithered on about how I got here and all the rest of it. When you get to a situation where, say you're like me and you're very fortunate and it doesn't cost you day-to-day worries anymore, but you need a procedure. So you go along and you have your little card from your treatment centre that says you have a bleeding disorder of unknown cause. And say, as in my case there last year, I had to have a cyst, a fairly sizable cyst, removed from my head and one from my arm. And I went to the surgeon pre that, told him I have a bleeding disorder of unknown cause. I'm a patient of the National Coagulation Centre at St. James's. Here is my card. This is the number of the hematology if you need to, or hematology if you need to speak to them. He looked at it, went, "What does that mean?" I said, "It means I have a bleeding disorder. Diagnostically, we can't tell you why I have it, but I have it. I'm not going to spout blood. I'm going to bleed the very same as everybody else, but just for a little bit longer. You need to be aware of that." And he literally tossed the card back across the desk and went, "It's not relevant here." Now, I don't know, this is pre my ERIN summit in Zagreb, so I wasn't advocating properly for myself because I didn't understand it. I didn't have confidence in the diagnosis. I felt that this was something that was perhaps told to me to kind of maybe fob me off is a hard word, but like it's just a hard turn of phrase. But that I didn't take it seriously. And how could I advocate when I didn't understand it? What happened was that surgeon went into the procedure room alone with me and then ran into issues. The cyst on the side of my arm, he couldn't get it to stop bleeding, so he pulled the stitches so tight that he turned the skin back on itself and it's scarred. Not a big deal in things. On my head, he actually went about washing my hair because the blood ran, and as you see, I have very light hair, so it actually looked worse than it was. And his exact words to me were, "I cannot let you leave here. You look like you've been assaulted." And I said, "Well, I did tell you I was going to bleed." I said, "And you dismissed it?" And he said, "Well, I didn't think you'd bleed that much." That's not professional carry on. Fast forward to, and I'm going to wrap this up very soon because I'm very conscious of the time. I'm stealing into what would have been Jennifer's time. I had a procedure a couple of weeks ago where I had a cardiac monitor implanted into my chest. Again, same thing. They liaised with the NCC, they put a treatment plan together, and that went fine. Fast forward to last week. So actually today's Tuesday. This day last week, I had cardiac surgery. I had a what they call a cardiac ablation to treat an overworking electrical system in my heart. I did the whole thing, went and spoke to the surgeon, said, same again, bleeding disorder of unknown cause. Just to dial back, I had ended up in A&E a couple of weeks prior to that with a heart rate of over 220 beats per minute, out of control. The way that the medical staff responded to the bleeding disorder of unknown cause was disgraceful. And I'm sure everybody here in attendance has probably had the same experience. Unknown cause, so they don't know what it is, right? So it's nothing. You hear unknown cause, that's what they hear, that's what they click into. And suddenly they're looking at you like, And if you're in the unfortunate position of having multiple sort of conditions, like so I would have high blood sugars and low blood pressure and things like that. And now they're going, but do you really have a bleeding disorder? Or is this just something you've latched onto? Again, I think, the issue comes with the word unknown cause. So you either get two responses. You get that's irrelevant. It's not relevant here. It's unknown cause. It's really nothing. Or, as in the case with the cardiac issue that I had last week, I was waiting for several hours, and other people that were waiting for their surgery had gone through. And I asked the surgeon when he came out, or I'd asked the nurse, I said, can you just tell me as to why is there a delay? Why am I back here? Like, and she said, we have to send for blood. And I said, for blood? I said, for what? Oh, she said, for you. And I said, for what? She said, for your bleeding disorder. She said, because she said, you're going to lose so much blood during the surgery that we had to have blood on standby. I said, we absolutely do not need to have blood on standby. I said, I've spoken to the surgeon about this. I said, at the consult, I spoke to you. I showed you the treatment plan. I said, this is practically non-invasive. I said, you're going in through a vein. I said, it's a very small access point. I have explained I am not going to bleed out. If I bleed like anybody else. It'll just take a little bit longer. I am on tranexamic acid. It's fine. And I was absolutely shocked by the lack of understanding that you would go and send out to have blood on standby. Now, you could say to yourself, oh, they took it really seriously. You could also say, actually didn't do the research properly. They actually didn't liaise properly with the NCC. They didn't get the information. So here I am again. I'm already stressed. I'm already worried. It's not a nice procedure to have to get done. And because of the lack of understanding, the lack of information or whatever, here I was again in this situation. And I would have to say what plays a big part in it is the name of the diagnosis. I really do think, I don't really, people when they meet you in an A&E situation or in a clinical setting or whatever, and you're saying to them half-heartedly, unknown cause, you're kind of dismissed straight away. So I'm wondering, I suppose, thanks for indulging me on telling this in a very long way. As I said to you, I stole Jennifer's time, but I think it's an experience that a lot of people would have. I'm certainly not special or unique in that, but it is worth reiterating. And I'm wondering, if other people have, when they've come across it, how have they handled it? And I would just like to thank you all for listening to me so patiently. As Fiona will tell you, don't ask me to speak if you're planning on being somewhere soon. But look, I'm here and I want to help, and I want to issue, this lovely heart skull. I would like to help in any way I can. And if talking about my experiences throws a light on it or helps anybody else, I am more than happy to do that. I'm well and I'm able to speak up for myself more or less. But when you're vulnerable, when you're already worried, when you're already scared, or if you're advocating for somebody else with a rare bleeding disorder, like, maybe a vulnerable adult or a child, and then you're worried about, are people listening to me? Are they taking this seriously? That's where you can run into a problem. And I think I would have to say, and I think I've mentioned this before, we need to get confident about advocating. And I just think maybe the term is not helping us in the confidence, because we're already starting on the back foot. You're already apologizing for the explicit nature of the condition. So I suppose that's my story, my experience, and my experience of it and my thinking on it is that how do we, like, looking to the future, how do we improve this for other people? So Flanagan out.
Thank you, Mary, for this really impactful story. We really, really appreciate to have someone who is completely open to talk and talk openly about the issues. We can only imagine how many patients, girls, and women are sharing your story, and what physical and psychological burden that is for them. So it is basically just showing to us that we just scratched the surface, and that is something that we really, really need to work with again together with healthcare professionals. So again, we will address questions to you. I see that we already have some in the Q&A part. So again, whoever thinks of a question, feel free to put it here, and then we can discuss that later. I want now to announce the second speaker. Our second speaker is Saskia Schols. She is an internist hematologist at the Haemophilia Treatment Center of Nijmegen, Eindhoven, Maastricht, Department of Hematology of Radboud University Medical Center in Nijmegen, the Netherlands. As a physician, she is involved in the healthcare of patients with acquired and congenital bleeding disorders, especially rare bleeding disorders such as very rare coagulation factor deficiencies and fibrinolytic disorders. Dr. Schols is the principal investigator of the nationwide cross-sectional RBIN study, in which she supervises PhD students with their scientific projects. She also participates in many investigator-initiated nationwide studies. She's a board member of the Dutch Society of Haemophilia Physicians and Dutch Society of Thrombosis and Hemostasis. Dr. Schols, since 2024, is the chair of the EAHAD working group for very rare coagulation factor deficiencies. And in 2025, she was appointed Associate Professor of Rare Bleeding Disorders of the Radboud University Medical Center in the Netherlands. So, Dr. Schols, the floor is yours.
Thank you very much, Stefan. I hope you can hear me all. Thank you very much for this very extensive introduction. I have nothing to add on it. And thank you very much for this invitation. And Mary, for this wonderful story you had. I was listening very quietly. It is very impressive. So what I'm going to do, I'm going to share the screen. I don't think I have the control to share the screen. Can you help me, guys, with...
You should.
The button is not giving me the opportunity to share.
Yeah, let me just try. I'm going to give you hosting rights for a moment.
That
Saskia,
sounds great.
just so you can take control. Now that should work for you.
Well, yeah. No, sharing is still not, I'm not able to share.
Okay, let me check again. Stefan, do you have Saskia's presentation? Because I can share it for her, perhaps.
I do. I will try to. Just a second.
You see, this is why we test in advance, and it worked. Ah, there you go. Excellent.
Okay, so,
Yeah.
Saskia, just let me know when to.
Yeah, of course, of course. So, well, I'm working as an internist hematologist in the Haemophilia Treatment Center of Nijmegen, Eindhoven, and Maastricht in the Netherlands. And for this presentation, I would like to focus on the diagnostic workup of patients with an increased bleeding tendency in our Haemophilia Treatment Center, to give you an overview of how we manage patients with a bleeding tendency coming for that diagnostic workup, and to combine it a little bit with some education on the hemostatic balance and what is being tested in each step of our diagnostic workup. Yeah, if we can proceed to the next slide. So, yeah, what's very important for recognizing and being aware of is that the prevalence of some specific bleeding symptoms in the healthy population is very high. almost 50% of women in the fertile period do have heavy menstrual bleeding, and 25% regularly have nosebleeds. Almost 20% have easy bruising, easy hematomas, and 18% does have a prolonged bleeding after dental procedures. So it's very difficult and very challenging to distinguish a bleeding tendency from what's normal in the healthy population. That's the first start. Can we proceed to the next slide? Yeah, so what we are doing and collecting information during the first visit when a patient is referred to our Haemophilia treatment center is we collect data on the duration and onset of all specific bleeding symptoms. What's very important is we have an overview of the medical history, especially for patients, adult patients, comorbidities are important. Think about cardiovascular comorbidities, liver function failures, and also medication use. It's obvious but important to mention. Not only think about the antiplatelet therapy and anticoagulation drugs, but also painkillers and the diversity of painkillers which are available nowadays, especially the non-steroidal anti-inflammatory drugs, which can be received everywhere. Herbs and vitamin supplements are also very important to get information on specific supplements. Family history, of course, and also specific questions about the bleeding tendency. What we use in our Dutch Haemophilia Treatment Center is the ISTH BOD score. And if we can move to our next slide. It's a very busy slide. Please don't try to read it from the top to the bottom. I will explain it. It's just an overview of this ISTH bleeding score. You can find it when you Google it. And this is our tool, which we use in every patient that is being referred to our Haemophilia Treatment Center. It's questions on 14 different items, organ-specific bleeding. And for every item, you can score either 0 points up to 4 points, depending on the amount of bleeding and the required treatment. So, for instance, for nosebleeds, if you have a nosebleed and if there is a blood transfusion required to treat that nosebleed, then you score 4 points. Afterwards, we collect all these score of each item, and then we have the total BOD score. And we said it's just giving information, an a priori risk assessment of what the risk is of having a bleeding disorder, a congenital bleeding disorder. For children, we defined a normal value up till 2, for men up to 3, and for women up to 5. And you see that it's totally dependent on the person with their individual characteristics, how high this score will be. For young people who didn't undergo a tooth extraction or invasive procedures, then the score will not be that high. That doesn't mean that there is no congenital bleeding disorder. That is very important as a physician to be aware of. We can proceed to the next slide. Yeah, just to give you an overview of the prevalence of the congenital bleeding disorders. So the most prevalent bleeding disorder is von Willebrand's disease. It's 1 in 100 people, up to 1 in 10,000, depending on the definition and the true bleeding tendency. For hemophilia A, it's 1 in 10,000 newborns. Hemophilia B, 1 in 30,000. And for the congenital platelet disorder, it's just like the same as von Willebrand's disease, 1 in 100 to 1 in 10,000, depending on the severity of the bleeding disorder. And for the very rare coagulation factor deficiencies, it's a prevalence of 1 in 500,000 to 1 in 2 million. The last one is for factor 2 deficiency and for factor 13 deficiency. But also this is for patients with a very severe factor deficiency. So for patients who are homozygously or compound heterozygously affected. The mild rare coagulation factor deficiency have a much higher prevalence. If we can see a next slide. Yeah, thank you. So when a patient is coming to our hemophilia treatment center, what we perform during the first step is some screening assays. For instance, a whole blood count, and we perform that to rule out a reduced platelet count, the PT and APTT to rule out severe coagulation factor deficiencies. Mild coagulation factor deficiencies can be masked by a normal PT or APTT. We have to be aware of that. Platelet function analysis, we perform it to rule out severe platelet function defects and von Willebrand disease, but we also perform the von Willebrand activity and antigen level, and on indication, the multimeric analysis. And in the first line, we also perform a fibrinogen level and factor 8 assay. We can move on. Yeah, and just a little bit of education. A defect in the first step of the hemostatic balance is when there is a vessel wall damage. First of all, a vessel is going to reduce its diameter. It's called vessel wall constriction. The whole idea is to stop the bleed and to control the bleed locally. Platelets that are moving and streaming through our blood are attached and attracted to this side of damage wall, and they're going to be activated, and they're sticking to each other and sticking to the exact side of damage. And that's our first line of screening test for platelets. And when you go to the next slide, you can see the first focus of our screening results. And when you go to the next slide, yeah, it's a closer look to the inside of the vessel wall. You see at the bottom the endothelial layer that is being damaged. Then very large proteins are exposed to the bloodstream, like maybe you've heard of it, collagen and von Willebrand factor. Platelets are going to attach to this surface and are activated, and then a whole lot of platelets are attached to this vessel site, and we call that the first plaster. It's very vulnerable. We need more to control the bleed, but this is our first step of primary hemostasis. We can move on to our next slide. So when there are no abnormalities in this first step, we move on to the next step. And we decided, and this is in our national guideline, that we are going to determine all individual coagulation factors, all the individual proteins, of course, to detect deficiencies, severe, but also mild deficiencies. And as you can see, we also perform factor 12. We know from experience that a deficiency in factor 12 does not lead to a bleeding tendency, but it can be a cause of a prolonged APTT. And that's also good to know. The last two tests are platelet function test, the light transmission aggregometry, and the platelet receptor activator and secretion markers. And those assays are very specialized assay that I think are only performed in specialized hematology laboratory wards. We can move on to our next slides. Yeah, so in our hemostatic balance, you see that the third picture is about the formation of a very firm fibrin clot in which all the coagulation factors are activated and fibrin is being formed. And together with this first plaster of platelets and von Willebrand, this is really the stop of the bleed. Yeah, we can proceed. A very complex slide is now presented. And of course, the only message I want to give you in this slide is that all the coagulation proteins are working together, and it's like a domino track. If one protein is activated, then all the others are rapidly activated in a series. And the most important action is that thrombin is being produced and fibrin, and that will lead to the formation of a very firm blood clot. And you can imagine that any deficiency in the factors you're seeing in this picture will lead to a less firm blood clot and can lead to a bleeding. We can move on to the next slide. So in our treatment center, when a patient with an increased bleeding tendency does not have any abnormal results, we will proceed to our third step, and that is a composition of fibrinolytical assays. Because we do think that in many patients with a bleeding disorder of unknown cause, with no abnormalities in the von Willebrand factor, no platelet function defects, and no coagulation factor deficiency, a fibrinolytic disorder can be present. And we also perform genetic analysis, either a single gene analysis when we do have abnormalities in the first steps, or whole exome sequencing. And in our treatment center, we have a panel, a filter of more than 150 genes that are involved in hemostasis and thrombotic disorders. And sometimes the conventional laboratory assays are absolutely normal, but we pick up some pathogenic variants in this genetic analysis. And that leads to a sort of diagnosis with targeted treatment plan. So that's why we perform it. We can proceed to the next slide. So I just wanted to show you in this slide that the fibrinolysis is a very complex step to degrade a fibrin clot. There are activators and inhibitors present in the bloodstream that regulate the fibrin degradation. So if there is a deficiency in the activator or in the inhibitor, that will lead to a disturbed fibrinolytic activation. We can proceed to the next slide. So the bleeding disorder of unknown cause, I think the definition is a challenge as well. Concerning our hemophilia treatment center, our definition is that we have to rule out acquired cause of bleeding. Just think about a vitamin deficiency, liver dysfunction, or a thyroid dysfunction. All the conventional laboratory assays have to be performed without any abnormalities, and there has to be an increased bleeding tendency, and that is also a very challenge. What is an increased bleeding tendency? We have the ISTH-BOD score, and we say that, well, there is an increased bleeding tendency if the ISTH-BOD score is above the upper limit of normal. And we just learned that for women it's above 5, for men above 3, and children above 2. But however, it's totally depending on what this patient has went. So it's also based on the intuition of a physician. And when we have defined this bleeding disorder of unknown cause, we establish a general treatment plan. And in this general treatment plan, most of the time we include tranexamic acid, like Mary already said, and desmopressin, DDAVP. And when there is some room left, we have a platelet or plasma transfusion. For instance, when the PFA, the platelet function analysis, is prolonged for a bit. We can proceed to the next slide. So in our treatment center, we collected retrospectively data from the previous 5 years for all patients with a bleeding disorder of unknown cause. It was 164 patients who underwent our third step in our diagnostic workup, the fibrinolytic studies. And after excluding 4 patients, 160 patients were included in the analysis. And 63 of them turned out to have a disturbed fibrinolytic assay, so a presumptive fibrinolytic disorder. and that's about almost 40% of patients with a BDUC. So I do think that a significant group of patients with a BDUC have a fibrinolytic disorder. We can go to the next slide. What we also performed is the ISTH-BOD score, and we compared the a group of patients without abnormalities in the fibrinolytic assays and with a fibrinolytic disorder, and we didn't see any changes, any significant changes of the differences between the ISTH-BOD score. It's the left bars, and the right bars are the specific fibrinolytic diagnosis. PI1 deficiency or a hyperfibrinolytic state. It's the light green one. And you can see there are no significant differences between the ISTH-BOD score. So that's difficult to rule out a fibrinolytic disorder. We can proceed to the next slide. Yeah, so my important take-home messages are that there is a high prevalence of specific bleeding symptoms in healthy population. And every hemophilia treatment center has its own diagnostic workup, even in the Netherlands. And I think a major group, significant group of patients who are diagnosed with a BDUC will have fibrinolytic disorder. And in January of 2026, in the Netherlands, a nationwide study will start, a BDUC study, which will be led by internist hematologist Floor Moenen from the Maastricht University Medical Center. And the overall goal is to collect information on the bleeding tendency and also to perform some research studies, such like proteomic analysis, to really reveal the underlying molecular diagnosis. And that's the last slide of my presentation. Thank you, Stefan, for having it under control.
Everybody needs IT support. Thank you, Stefan. That was great. Thank you, Saskia. What a presentation. And I think you've really set the scene for us to have a really rich conversation. And there's already lots of questions in the chat, which is really great because this is obviously your time as a patient community, but also as healthcare professionals as well to engage on this topic. I have the pleasure to add and introduce another native English speaker, Dr. Alison Dougall, who's a professor of dental science and a consultant in special care dentistry at Dental Hospital in Dublin. She leads the Child and Adult Dental Public Health Department at Trinity College Dublin, and for the past 20 years her team has provided dental care in again the same centre as Mary attends, the National Coagulation Centre in St James's Hospital, working closely with the comprehensive care team and indeed the research group as well. In academic terms, Alison has published more than 50 peer-reviewed papers and received major recognitions, including the John Tomes Medal from the Royal College of Surgeons in the UK in 2022 for her global impact of her work. She has served as a dental advisor for the latest WFH guidelines and received the Health Leader of Ireland Award in 2016 for creating oral care pathways for people with bleeding disorders. She's the former president of the International Association for Disability and Oral Health, and Alison has been a staunch volunteer with the EHC for over 15 years. So Alison, over to you. I hope you can share your slides. If you can't, Stefan will happily intervene again. Aha, there we go. Excellent.
There we go. Okay. Well, let me just get that going. Good evening, good afternoon, everybody, and thank you for listening to a dentist, because I've been lucky enough to work as a dentist fully integrated to the National Coagulation Centre. So we have lots of data, and that can be useful, I think. So I've got lots of things and lots of questions to raise, so I'm going to get straight on, and thank you for your interest. So I'm a keen reader, call me a nerd, of scientific journals, and it's great that there are now publications coming out. It's even become, let's say, trendy to look at a bleeding disorder of unknown cause, and it's been a particular interest of mine for many, many years. I read this article and looked at the future perspectives that were recognised by this up-to-date publication. And I'm going to talk about 3 areas and how that pertains to oral health. The first question that was posed as a gap of knowledge is, what is clinically relevant increased bleeding? When I spoke to Mary, about this presentation, she wanted to know what's normal bleeding from the mouth. So we'll look at that. We're also, going to look at what's optimal treatment in BDUC for people having dental treatment, and how can health-related quality of life be improved in BDUC with oral health. So let's just talk a little bit about oral health and what I mean by oral health. It's not all about teeth. It's not all about turkey teeth or whitening teeth, although I think we have to recognize that oral health is multifaceted. It includes the ability to speak, kiss, smell, taste, touch, chew, swallow, convey facial expressions with confidence, live without pain, discomfort, and disease. Let's say that there is no health overall without oral health. But sadly, oral health problems are common. So whereas in a lifetime we may have 1 cardiac intervention, we may have 2 children, then dental procedures and dental treatment is something that happens often. So it's something that is relevant to people with a bleeding disorder. Not only because it often made part of their diagnosis, it was the trigger to their diagnosis, that really severe long bleed after a tooth extraction. Or most importantly, when people finally get their diagnosis, they can go back and make sense of the past and think, well, of course, I always bled at the dentist. I should have known. Why didn't that trigger my kind of investigations? So I think oral health has a special place in the history of people with BDUC. It's a massive part of diagnosis, but often ignored. I heard Mary say at the beginning, of course, I'd always bled when I went to the dentist, of course. And I think that's really commonly what you hear, that people bleed for longer from their mouth. But let's start with the question, what's normal? What would typical people experience? Well, the thing is, normal is this is called a bell curve. It means in the middle is the typical population, and each side people will have varying degree of anything. But as far as normal bleeding, for a normal extraction in a typical population, for somebody with no liver disease or nobody taking anticoagulants, normal bleeding we would expect stops within 20 to 30 minutes with pressure on the gauze. It may ooze slightly after that, but it would never, in somebody without a bleeding problem, result in escaping blood from the corners of the mouth. It would never re-bleed after 24 hours. When it stopped, it should have stopped. Anything other than this is very, very atypical. I think it's interesting in the BAT score because they want 2 bleeds to be doubly sure. And yet, if you read the literature, I did my own PhD study about the experience of bleeding from the mouth. It's awful. It's tasting blood, it's swallowing blood, it's worrying where you're showing blood. It really does result in anxiety. I'll talk about that in a second. But also people with a bleeding disorder, following a cleaning, normal bleeding, even in someone with gum disease, should finish in a few seconds or last a minute. For absolute maximum, should never rebleed. Anything other than this is abnormal. And bleeding from the mouth, what it does is it adds to dental anxiety. It means that people are scared to go. It means that they have trauma from when, as a child, they had their mouth packed. So this is like almost post-traumatic stress. Most of the population are nervous about going to the dentist. It's a very intimate part of the mouth. Add a previous bleed to that, and people will really, really fear going to the dentist. And anxiety is a real thing, and it's associated with dental neglect. It's associated with avoidance behavior, which obviously leads to more and more problems, the need for future treatment. And then if people finally pluck up the courage to go to a dentist, then they'll have the dentist who's terrified of them. I don't know who's more scared, the dentist of the patient or the patient of the dentist. And what we have developed in Dublin is a specific letter for patients with BDUC that very clearly lays out for them and for the dentist what is possible and what should be carried out. Because I've been in this job for 20 years. I've trained dentists. I've gone and talked with dentists. This is not common. So they may go to a talk 12 years ago and they'll have forgotten that information. So however much we train them during training, it's about the patient having the expertise to know. It's about them being the coordination between their team, not relying on dentists or even surgeons sometimes, because this is rare. So I think it's about empowering patients to have the right information. So regarding giving the patients the right information, what's the optimal treatment for people having BDUC, who are having dental treatment? In this latest article that I talked to you about, this is shocking. Bleeding after dental procedures between 36 and 84%. That's shocking, 84%. It shows that BDUC can be reliably diagnosed via dental procedures. So I would question why it doesn't play a better role, but this is shocking. And what this means is that we need guidance. We need guidelines, but guidance is difficult because this is a rare condition, and rarely do people have enough patients to be able to do the type of trials to be able to give reliable information. However, I've been collecting data for quite a long time, and because BDUC seems to have a problem with dental surgery, I was shocked when I read that. We have gone, and I'm presenting some details at EAHAD in next February. EAHAD is coming to Dublin. Because the question was, if 84% of surgical procedures are bleeding after dental extraction in BDUC, is it inevitable? Are the surgeons doing just as Molly said and ignoring the fact that it's important? Are they following the wrong guidance? Do patients know what they should be asking for? So we carried out dental extractions on 47 consecutive patients with BDUC. So when you're looking at a case series or something like this, you always want to see consecutive patients, because you don't want clinicians to cherry pick the good results. So this was 47 patients in a row having teeth out. Their BAT score was between 6 and 20. As Saskia said earlier, anything less than 6 is considered perhaps a possible bleeding disorder. People are still not sure. But these patients, and we use dental extractions in our centre as a diagnostic. I'll talk to that if we ever have questions at the end. They went under 71 dental extractions following the Dublin protocol. And the Dublin protocol is about haematologists and dentists, and especially patients working together. And what we do is we assume, we know this is unknown cause, but we assume it's going to be either platelet function, or it's going to be irregular fibrin mechanism. So we, when we're taking teeth out, take account of both situations. So excuse for the dental phobics amongst you. Here's a picture on the left of a root of a tooth that's left in that needs to be extracted. This is a crown that came off. This is what patients really dread when, as they say to the dentist, you've got nothing to hold on to. But this is a typical extraction. And on the right is the socket where we've taken the tooth out. So that, as you can see, is bleeding. And it's going to be bleeding from soft tissue, from the pink mucosa. It's also going to be bleeding from bone. And this is why dental extractions bleed, because it's both gum and it's bone. So the first thing that needs to be done in the protocol with the guidance is local anesthetic, that's the numbing, needs to have adrenaline in it, because that causes constriction of the blood vessels. It reduces the amount of blood in the first place. Then we use special packs. Now, these are readily available with dentists because we use them all the time for patients taking anticoagulants, warfarin, apixaban. So dentists are taught about this. They always have it in their cabinets. It goes into the socket and it gives something for the platelets to stick onto. It traps them, it causes them to swell, and it really helps those platelets stick together. So if people have got a platelet function disorder, even if it's not been recognized in a test, it will really help stop the bleeding straight away. So when Mary was saying, I bleed for longer, this will stop the bleeding almost immediately. And then the next thing that needs to happen is that pack needs to be stitched in place, because it keeps it in the wound. And it also means in the days that come, the wound is going to be very neatly held together, because it's the mouth. We can't put a plaster on it. We've got to eat, speak through that. And so we're traumatizing. So the stitches help keep not only the pack in, but they keep the edges from the wound very neat. Tranexamic acid, cyclocapron, is absolutely essential. We follow the Cochrane review, and we use in our protocol oral tranexamic acid. We start it the night before so that people have got a good plasma level, and we continue it for 5 days afterwards. This is the drug which is going to mean that if there's a fibrinolysis problem, if there's a fibrin issue, then the tranexamic acid is going to help strengthen the clot. It inhibits the clot being broken down. Now, some people use mouthwash, some people use tranexamic acid in the socket at the time. We don't use that. It's not readily available by dentists, and we use tranexamic acid systemically to get that effect along with our pack. And then really, really important, in all of the dental literature, it's what happens afterwards that's the most important. Patients have to really understand their role in healing. Soft diet, no smoking, gentle saltwater rinses. Patients are so anxious about getting infection in a tooth, in a socket, that they're rinsing and they're washing the clot away. So we don't like vigorous rinsing. So in our test, we had DDAVP on standby because, you know, that's one of the surgical interventions. And do you remember the 84% bleed rate? Our bleed rate, wait for it, 0%, 0% bleeding. So we can be really confident in being able to promote a very simple protocol that general dentists with guidance can follow. And I think that's really interesting, because we can add bells and whistles and we can add all these other stuff, but dentists don't have them. It adds barriers. And I think this is a very straightforward protocol looking at platelets, fibrin, and patient behaviors together, which can give people confidence. So we're delighted with that. We send off all of our patients with BDUC with the protocol written down, and that's, you know, we're confident with that. The other thing that I noticed back in this article was mucosal bleeding. 53% of these patients had gum bleeding. And those of you who heard me speak before will know this is my bugbear about bleeding. Healthy gums don't bleed in patients with bleeding disorders, even with bleeding disorder of unknown cause. And I know most of you who are patients will think that's not true, my gums bleed. So this is the slide that shows why healthy gums don't bleed. If you look at the picture, you can see around the gums is very light pink, firm. That's not mucosa. That is epithelialized skin. That's the same as the palm of your hand. It's not mucosa. So mucosal bleeding does not equal gum bleeding. However, If gingivitis develops, if plaque is on the teeth, it causes an inflammatory response. Go back to that pale pink gum in a healthy gum. Look at this now. We've got inflammation and blood vessels around the necks of the teeth, which is an inflammatory response to plaque. This is really common. It's the most common disorder in the world. And in a general population, we would have a little bit of blood on a toothbrush. And they'd rush to their doctor or they'd rush to their dentist and say, I'm bleeding, I'm bleeding. In a patient with BDUC, if they've got that inflammation, they're going to have much more bleeding than is typical. And when we did a survey about 20 odd years ago now in Australia, what we found was people with bleeding disorders, including BDUC, when they see that blood, stop brushing their teeth or stop doing it properly or use mouthwash or use a really soft toothbrush because they think they're causing the bleeding. And so it gets worse and worse and worse. And then this is the picture of people following their brushing their teeth when they've got gingivitis and a bleeding condition, and it gets worse and worse, and that's when you get periodontal disease. So bleeding is sometimes inevitable if you stop brushing teeth properly, but it's treatable. How's it treatable? It's treatable with oral hygiene and having your hygienist work with you. Brushing systematically to get rid of plaque is really important. Only by removing plaque thoroughly will you stop the inflammation and stop the gums from bleeding. I don't mind electric toothbrushes or whatever, but what you need to do is use disclosing tablets to stain the plaque so you can see where it is. Then you can aim for it and you're not so worried about traumatizing your gums. But traumatizing the gums is something that, you know, is difficult to do, but you clean that plaque off your teeth. For patients who do that, they are going to see bleeding such as this in their mouth. So we always have our patients, when we're really working with them to get their gums healthy, on a course of tranexamic acid, or even with mouthwash, tranexamic acid mouthwash to rinse with afterwards to stop the bleeding. We've got lovely research to show in von Willebrands and whatever that it takes about 4 weeks of really good oral hygiene to completely eliminate the bleeding. So I think it's really important, bleeding gums, not only because it affects quality of life, but also it's a portal of entry for bugs to travel to the heart, to you know, we've got huge evidence now of bad gums, gum disease increasing, or certainly making diabetes work, risk of heart disease, joint disease, even early onset dementia or low-term pregnancy. So there's so many reasons to look after your gums when you're BDUC. And we have all of those protocols to be able to help you to, number one, look after your mouths, but number two, have safe dental treatment and not be scared of the dentist, but more important, so your dentist isn't scared about you, because you know, many of them have had people bleed after they've worked. My job is to educate them to know to signpost the patient towards a diagnosis if they've got a significant bleed. So we're going to be working very hard at that in EHC, but I'm here for your questions in the meantime. Any questions? It's always good to ask dentist questions when they're not hovering above you with horrible looking instruments and whatever. But no question is too simple. And thank you very much.
Thank you, Alison, for amazing presentations. I caught myself having a sudden urge to go to brush my teeth while I was looking at the presentation. But thank you so much. I mean, always your presentations are amazing, and this is really amazing data that both patients and healthcare professionals can use in again joint advantage. So I want to thank all three speakers for sharing their insight. We have around 20-ish minutes to address the questions we have in a question and answer area. In the meantime, if someone else wants to weigh in, feel free to raise your hand so we can discuss it. Before the question, I will just read Chris's comment as to what Mary was saying, and she says, I can totally relate with your experience. I was a BDUC for many years. I now have a diagnosis, but it actually doesn't make any difference to how my medics regard me. My advice is phone your center when people won't listen to you. Unfortunately, again, as we mentioned, we can just imagine how many people have same or similar stories, such as yourself, Mary. There is a question from Anna and Elizabeth Tolve. They asked, what did your tests during the investigation show? My daughter's and mother's test doesn't show any deviations, but their clinical problems are challenging and quite severe at times.
The test just came back as that there was the medical presentations and the experiences were showing, yes, a bleeding disorder, but the diagnostics and the results coming from the blood tests and I tested it showed nothing. So they said they can see that there's a bleeding disorder there, but they can't tell me what. I don't know, but that's literally unknown cause. So I'm sorry, I have nothing, anything more concrete than that, which I suppose is the crux of the issue, isn't it?
Okay, I see one question is, but Alison already referred to that.
What's that?
That is regarding hemophilia, right? So it's maybe again to keep to bleeding disorder of unknown cause. And again, feel free to reach out. I believe the speakers will be happy to discuss this with you later on. Another question is, thank you for sharing the experience. I'm wondering if you perform VWF multimer analysis in the first screening tests. I think this is the question for Saskia, right?
Yeah. First, we had a multimeric analysis, but now we, in the first step, we perform a von Willebrand factor antigen and activity level. And if both are normal, we are not proceeding for the multimeric analysis because it does not give us extra information. Only when the fibrinogen activity level, antigen level is reduced, then we proceed for a multimeric analysis. Or if there is a suspicion of a acquired von Willebrand disease. But yeah, then we have certain comorbidities that will suspect this specific acquired von Willebrand disease.
Again, we can stay with you because this is also a question for Saskia. For BDUC nomination in all countries, should all the tests you showed in the slides based on your national guidelines be performed?
Well, I think the test I've shown you in the first and the second step, I think those are very important ones. So, of course, the von Willebrand's disease, platelet function analysis, even with light aggregometry, and all the different coagulation factor activities. That is very important because you can give targeted therapies when there is a disturbance in a factor deficiency or platelet disturbance of a Willebrand factor. For fibrinolytic assay, it's difficult because many assays are not clinically validated and there are a lot of research for fibrinolytic testing. So I think that is difficult, but the other ones, I think it's important for every hemophilia treatment center to perform these assays or to have the ability in some way to perform it. Yes.
Thank you. Again, for Dr. Schols, do you have any opinion about doing fibrinolytic assays using modified TPA rather than by spiking whole blood?
Yeah, there is an advantage of whole blood is that you can perform the test immediately and don't have these pre-analytical difficulties. But the clinical validation is difficult. So the translation of the results to a specific patient, it's very difficult to have a specific meaning. So I think we have to go ahead and proceed all these fibrinolytic testing, but it's in a research setting. And the next step for us as clinicians and researchers is to perform clinical studies. And then we have the opportunity to really include them in guidance, in laboratory guidance.
Follow-up question is, have you ever noticed that a significant percentage of patients with BDUC are hypofibrinolytic? If so, how would you explain it?
Hypo. Yeah, I know hypo is just the other way around. I do think that patients can be hypofibrinolytic, but I think that's more a kind of compensatory mechanism, such like when you have a platelet function defect or von Willebrand disease and you perform the other coagulation factor levels, you see a little bit of compensation. Your hemostatic balance is trying to compensate for that missing or defect factor. So yeah, there can be patients having a hypofibrinolytic state, but for the moment it's very difficult to assess it and to have the right laboratory measurements.
And
Yeah.
would you suggest the minimum coagulation laboratory tests need before diagnosis of BDUC?
Yeah, minimum, I think, just to perform all the tests in step 1 and step 2. So definitely ruling out the platelet function defect, von Willebrand's disease, and all the coagulation factor defects. And when you perform a good set of anamnestic questions to rule out acquired causes. So liver function defects and vitamin deficiency, that's still something that's going on in the population that have to be ruled out. Yeah.
Thank you so much. Feel free to again to
Yeah,
raise your hand.
for me, I've got a comment. I noticed that Molly talked about a surgeon who'd got blood, who'd got whole blood. And I think this is one of the common things, which is the misconception, because it hasn't got of unknown cause. People assume there's no treatment. And I just wonder if Saskia would outline perhaps the treatment hierarchy. For myself, if I'm doing dental surgery, only for the most severe surgery in those patients who've got really high BAT scores would we use DDAVP, for example. Very, very, very rarely would we ever bring in platelets. But I think that this is a common misconception, I think. And I just wonder if the panel or both have got comments about how we can actually communicate this hierarchy of interventions, because it's not unusual for surgeons like Molly's to say, oh my gosh, I've got to use real blood because I've got to use whole blood because there's nothing else that works. And I think that's something that a story that we hear quite commonly. I have new hematologists come and work with me and they automatically think you've got to have DDAVP or platelets for oral surgery. So it's a very interesting hierarchy of when tranexamic acid is good enough, when DDAVP is going to be introduced, is there a role for platelets? And I just wondered if Saskia or Molly had got a comment.
Molly, would you like to say something first, or?
Yes, I suppose, thank you, Alison, for raising that question, because it does feed back into your lack of confidence then in how you have introduced the condition or diagnosis to your healthcare provider. Have you start to doubt yourself about, have you not advocated for yourself correctly or clearly? Then you start to worry about, have they misunderstood it? And then you start to develop doubts about the procedure itself. Now your whole worry goes into, obviously, the competency of the healthcare professional, but their understanding of what is happening, that they've gone to the worst possible case scenario. And so it goes back to exactly what you're saying, this lack of understanding of what's going to be needed. That they think that, like, as I had said, I'm very mild. So I'm not going to start pouring blood on the table and trying to understand that. But when you have somebody who is, in a surgical capacity or a healthcare provider, and they're saying we've gone out and got whole blood, it's really disconcerting. It's really unbalancing. So absolutely, yeah. Where do you start? Like, when somebody presents you with that information, you're just in shock and disbelief that it's come to that. So I would be very interested to know kind of, how do you present for yourself in that instance? What, I think we need a few in stock phrases or sentences that that will hit the spot for healthcare professionals straight away, that, you know what I mean, that we're probably not conveying it correctly either because of our own lack of understanding and confidence in a disorder of unknown cause.
Yeah.
And in our treatment center, we for every patient with a diagnosis, or even BDUC diagnosis, we establish a general treatment plan. And we have a three-step treatment. So the first step is for minor invasive procedures, minor bleeds, then proceeding to moderate bleeds, and the third step is life-threatening bleeds or the very big, very large invasive procedures. And we have targeted therapies for every step. Every patient received this treatment plan. But of course, we instruct our patients very extensively during every follow-up visit to contact us if there is to be an elective procedure, a dental procedure or a procedure, an invasive procedure at the general practitioner or in a hospital. And what we're doing then, we're calling the surgeon, the dentist, or every person is going to perform this invasive procedure. And we're asking about the extent of the invasive procedure. And then we establish a individual operating plan based on the general treatment plan. And then we really hand over this operating plan to the surgeon to be aware that the targeted therapy is being provided and to prevent some strange things that they are coming up with. Yeah.
But just to come back on that, thank you, Saskia. This that was also the protocol that was followed in our case, where the surgeon was made aware a couple of weeks prior to the surgery that they would need to liaise with the HTC, and then they did. They got a treatment plan. I got a copy of the treatment plan, and it was laid out what was going to happen, that the tranexamic acid was going to be given. I even brought it with me on the day and gave it to the pre-op team and said, this is what's happening. And they still went and ran with, we need to go and get whole blood. So all those protocols and those steps happened. And we still had, as you said, the crazy follow-up then of going further with that. Yeah.
But I think patient self-advocacy is something that is such an important thing, especially when you've got what would have been considered a relatively mild being. So I'm not for a minute saying it is, but people with very severe traditional get to become their own experts. It's more difficult to acquire that confidence. But I think it's part of the training, and I think it's part of any group that is looking after or advocating for people with very rare or with something that might be in the past considered not particularly severe. I think it's key part of any training or a self-advocacy, role-playing, practicing, writing down things before you go to see someone to make sure that you're confident in what you'll be going to say, and standing your ground when you know that you are informed correctly. So, but that's a skill that takes huge confidence, and that takes time. But I think it's important for parents of children and for people as they get older, and they're going to need more surgical interventions going forward into older age. So it's about getting that confidence and getting that information. And us as researchers and as clinicians need to make sure that we really concentrate on finding that information for you so you can be confident in the science. So I think it's an important part, Mary, and I think that's really you've summed that up really well. You're an intelligent woman. You're very well informed. Now it's about having the confidence to assert your opinion. So that I think you've hit the nail on the head.
Yeah, thank you. Good advice.
I'd never thought about the name being an extra barrier. But because it's already changed its name from what I was familiar with, so perhaps needs a new rebrand. Yeah.
Well, I often thought about, when you go into any
Yeah.
sort of a
Yeah.
diagnostic situation,
Yeah.
and even if it's to your GP or it's for anything,
Yeah.
the first question is naturally is, where does it hurt?
Yeah. Yeah.
And I suppose when you're going into any sort of a situation as a person with a BDUC, the point of pain is that uncertainty of that as soon as I say those words, unknown cause, I know I'm going to be dismissed.
Yeah. Needs to perhaps be called bleeding disorder X or bleeding.
Yes.
Something that's got a bit of a brand to it.
Yeah.
But I will warn you that even when you have a specific diagnosis, that is not a guarantee that the surgeon will take you seriously.
Correct.
I have a lot of cases of carriers of hemophilia A or patients with only a mild factor deficiency who are also get their card being tossed over the desk because they really don't know. And this is one remark that I really want to make and tell the patient population. In the Netherlands, there is a trending shift of private clinics that's being that's rising everywhere for eye and plastic surgery. It's very important to be aware of that. Physicians working there are even have less knowledge about coagulation disturbances. So as a patient, when you go to a private clinic, be aware that's even more difficult to receive the perioperative hemostatic care. So maybe the waiting list is less in those private clinics, but the care you receive, especially when you have a congenital bleeding disorder, is less. So that's very important to be aware of. I think all the plastic surgery will be mad for me by saying that, but be aware.
and the cosmetic dentists.
Yeah.
Excellent. That was a really good conversation. I see one more question in the chat, and if anybody has anything burning, we have 2 or 3 more minutes, so please feel free to jump in. So Saskia, back to you again. Can you have a bleeding disorder of unknown cause if your tests are normal, but you have several bleeding issues?
Yeah, that is exactly the definition of a BDUC. So yes, that is BDUC. Yeah. So tests are normal, but still you have an increased bleeding tendency.
And advice maybe for a patient in that situation, Saskia, how do you keep going? How do you push forward? How do you advocate for yourself?
Well, it's very important that you have this card and a general treatment plan, but also to come to the follow-up visits in a hemophilia treatment center, because that is the backbone of a healthcare that is being provided, so that your physician, your hematologist, is updated on the medication you use and can really educate for when you go to the dentist. Please be aware, any invasive procedure, just take your tranexamic acid tablets. Very, very important. So the follow-up visits are important as well. That's the first step.
The BAT score as well, the bleeding assessment tool, if people aren't familiar with it, there's a self-BAT, but will document your bleeding. Do you have bruising? Did you have bleeding following surgery? Anybody in your family? And you can score yourself. So it's always really good for people who aren't perhaps getting traction from their doctors or hematologists to complete the self-BAT assessment, which actually is the phenotype it's going to show. And that, as Saskia was saying, is the definition of bleeding disorders of unknown cause. And then it's a diagnosis by exclusion of everything, and looking at past surgeries, nosebleeds, all of those things that score you. You heard us talking about a BAT score of a certain level. And it's about the bleeding experiences that you've had during life. So this is a really important tool for those people who perhaps have got normal tests but bleed. It's to document that.
Yeah. And again, it's about arming yourself with the information, right? And keeping track. So one final question, and you touched on this already, Saskia and Alison, in terms of planning for operations and that coordinated care. But I have a broader question in terms of different specialities preparing and collaborating effectively, not in an emergency. So how to provide that collaborative care for patients with BDUC. Any comments?
Well, in our Haemophilia Treatment Center, we have a lot of multidisciplinary meetings with the gynecologist, the cardiologist, orthopedic surgeon. So we have very many discussions with these specialists. And for a patient, it's very important when he goes to a specific medical specialist to tell it the hematologist if there is any elective procedure going on.
For me, regarding dentistry and oral health, there's an advantage with having a dentist because it's someone you're going to see regularly, hopefully. So my advantage is to see somebody when you haven't got problems, to register with a dentist, have a dental home that you're going to go to regularly. You can train that dentist. You can inform that dentist. They may be slightly nervous to start with. They may not be sure, but you're the conduit between the two of them. And the last thing that you want is to rock up with someone for the first time who's never seen you needing an invasive procedure. So build a relationship. Really important to have a dental home if you've got a medical condition, especially a bleeding disorder. You can teach the dentist all about the condition and they'll be interested about it and they'll get better and better and more confident. So don't just rock up with the problem. That's my advice. And I think it's really important.
Great advice. Thank you both so much. Stefan, back to you.
Thank you, everyone. Thank you, Fee. We are a few minutes over time, but I want to thank all of you for staying with us. I would like to sincerely thank our speakers for sharing their insights on such an important topic. This is really more than valuable to start a conversation in this direction and to maintain it. I want to thank all of you for joining the discussion. As we heard today, behind every set of data are real people and real personal stories. So with that in mind, it is up to all of us to keep driving the conversation forward to make this disorder a little less unknown than its name suggests. So thank you all once again, and I wish you all a wonderful rest of the evening.